Absolutely.
Yeah.
Absolutely.
Awesome. Well, let's dive
Brilliant.
in.
Of
Thank you so
course.
much for
Brilliant.
being here. Dr. Jatinder Hayre, you are the lead author, the primary author of this amazing research on the health equity pyramid. And I found your work just from researching online and my own day-to-day reading. And it really struck me as being sort of this groundbreaking piece because I think it's taking into account, like you mentioned, decades of previous works, but also the sort of past 5 or 6 years. And even after the pandemic, right, we've seen a lot of people trying to understand the cracks that laid bare in our systems around
Yeah.
equity and who has access to what treatments and when. And
Yeah.
so, and specifically looking at policies as well. And I love that you guys integrated that in this piece. So, just a quick introduction on you. You are an academic medical doctor and public health researcher whose work examines how health systems create, perpetuate, and ultimately reduce health inequity through evidence informed policy and implementation science. Your research has informed national and international policy discussion and is advancing the agentic demand theory now, which is your new framework for understanding why healthcare systems systematically advantage some populations while disadvantaging others.
No,
Did
fabulous.
I
Thank you
did
so
I
much for
summarize
the
it?
you did that was absolutely perfect. Thank you for the warm introduction, Haley. And I just want to say thank you for getting this event sorted and all the
Oh,
fantastic work you do in promoting public health in
thank
various
you.
different sectors. So wonderful. Thank you so much for
Thank
that.
you. Thank you. And for those who don't know me, my name is Haley Sayers. I work in public health policy. I have a consulting firm based here in Los Angeles, California. And I'm really interested in health equity and how do we leverage sort of public health entrepreneurship to fill those cracks and gaps in the systems that we're experiencing.
Brilliant
So let's
stuff.
dive in. I want to pull up the health equity pyramids. I think that really shapes the conversation
Yeah,
and gives folks a visual to really look at while we're talking about this.
absolutely. Yes. Yeah. Fabulous. So I can see that that's directly from the paper. Yes.
Yes. So walk us through sort of the start and the design of this and how this really shaped the design of the study, what evidence you incorporated from population level impact,
Yeah.
and how this relates to how we think about health equity in terms of designing interventions, designing policies to address those gaps.
Brilliant. So I'll start off by saying, Haley, that the central finding is that population level impact comes less from changing individual behavior and more from changing the systems and the environments in which people live. Now, this is the fundamental shift in thinking that the health equity pyramid captures. So, just to walk through the umbrella review, we synthesized 35 systematic reviews and we consistently found that interventions requiring the least individual effort produce the greatest and most equitable population benefit. And in sort of summary, this is actually what the agentic demand theory is. It sounds very complicated, but actually, if you distill it down, it
Yeah,
is actually quite simple. So we found that fiscal policies, legislation, housing, and environmental interventions improve health because they operate universally rather than relying on people to repeatedly engage. And by contrast, there were interventions that centered on education, counseling, or behavior change, and these often produced smaller and less equitable effects. Now, they can certainly improve health, but they tend to disproportionately benefit those who already have the resources, the health literacy, and the capacity to act on the information they receive. That does not mean that individual level interventions have no place. Rather, the evidence suggests they are unlikely to reduce health inequity when implemented in isolation because they leave the underlying structural drivers of inequity completely untouched. Now, ultimately, the pyramid encourages us to think how we design public health programs. If our objective is to improve equity at a population level, we should prioritize interventions that reshape systems and reduce barriers rather than
yeah,
expecting individuals to continually overcome them. And I think we had some discussions as well, Haley, that the sort of conceptual framework, this
Mhm.
agentic demand theory, is actually very simple to
Yeah.
understand. It's not something that we discuss in stuffy academic environments, but actually across different sectors, lay
Definitely.
people, policymakers, stakeholders of various different disciplines. And I think that's one of the nice aspects of the research and disseminating some of these
Oh yeah.
findings.
Oh yeah. Like when I first read this, I could think of so many examples in my own work and things I've researched where I'm like, yes, we needed this to
Absolutely,
think
yes.
about in terms of what we're
Yeah,
designing because it's so easy to um I think also you guys mentioned this as well, like without accounting for bias, right? Whether you're the clinician or a
yeah,
policymaker, you're unintentionally possibly creating harm. And we see that a lot in policy as well, right? These unintentional
absolutely,
consequences that when you're
absolutely, yes.
designing an intervention or
Yeah,
policy, you have to think about. And sometimes we can only think about them after we've studied the effects, right? And so now with this work, we can say very
of course.
clearly
Yeah,
that, not everyone can or will pull themselves up by their bootstraps, right? And get what they
absolutely,
need. We need to figure
absolutely.
out ways to help people now
Yeah,
that don't
yeah.
require so much initial input or understanding.
Absolutely. Absolutely. And the one thing we find about agency as well is that agency itself is structurally and socially patterned. It
Yes.
requires a lot from an individual. And if we sort of deconstruct all the social determinants of health, if we imagine the Dahlgren and Whitehead rainbow model in front of us, agency requires the sort of time investment. It requires
Yep.
financial resources. It requires an underlying amount of health literacy in order to engage in the first place. It requires sort of educational
Yep.
capabilities as well. So there's a lot that goes into agency itself, and it is very much socially mediated and patterned. And I think that's what ultimately determines your ability to engage or disengage with uh,
Definitely.
with um, different sort of policies and interventions.
I believe in your research, you guys also defined agentic demand as the time you have available, right?
Yes.
Which is a
Yeah,
huge conversation in terms of time poverty and not being able to go to a clinic at
absolutely.
a certain time, or
Yeah,
all those things affect your ability to access care in a timely way as well.
absolutely. Absolutely, yes, yeah. And the one thing that we found was that there is a middle ground. There is a middle ground where there are certain health system
Mhm.
interventions.
Yes.
So if you look at, there were some papers on screening for hepatitis,
Mhm.
for example, and some digital interventions that were
Mhm.
firmly embedded into the healthcare system. Now, these interventions and these policies do have a role and they do have a place, but the key element of them is that they were culturally tailored and mediated.
Yep.
And they were also specified to the exact um, socially disadvantaged population, but also clinically disadvantaged as well. And there was that cultural social tailoring that was very
Yes.
important, that accounted
Yes.
for the lack of agency and that lack of time investment. So that was very important. And there is that middle
Yeah.
ground, there is that scope for such interventions, but only with that caveat that they have to be culturally, socially, clinically tailored to the intended population.
Very intentional design and
Absolutely.
probably some
Ab-
upfront conversations and qualitative research with your patients to figure out, okay, this is actually going to
Absolutely.
work. What are we going to,
Yes.
are there going to be
Precisely.
barriers that we're not seeing now in terms of access to
Precisely.
digital? I think when we talked about this too in some of your future
Mhm.
work, designing those implementations and leveraging digital technology, but that sometimes those apps may not always reach folks in the same way. And that can also create that unintentional gap.
Absolutely, absolutely. And would it be okay, Haley, if I do just talk about that next sort of
Yes.
iteration of the
Yes.
research? Because
I'm
this is
curious.
absolutely, it's precisely what you mentioned. It's precisely what you mentioned. So the next sort of shift in our research is to go from intervention taxonomy and towards health system architecture and design.
Yeah.
So rather than simply asking whether an intervention is upstream or downstream, we should ask what it demands of patients and who is least able to meet those
Yeah.
demands. And how systems can be redesigned to reduce them. So this is essentially my doctoral
Yeah.
project that starts this September, and it's
Amazing.
translating this into a testable implementation framework through digitally enabled chronic disease management. And the ambition is to create systems that identify when patients are struggling to meet those demands and respond proactively, rather than expecting patients to continually adapt to healthcare. And as we've
Yeah.
discussed, navigating the modern healthcare system, irrespective of whether you're here in Norway or my previous sort of arena in the UK or the USA, all health systems are increasingly complicated to
Yeah.
navigate. I mean, the setup and the architecture of the health system varies, of course,
Of course,
and
yeah.
the degree of complexity and fragmentation also varies. But the one thing that we see is that complexity and difficulty in navigating is pretty much across the spectrum in different
Yes.
health systems and
Yes.
different healthcare system setups. So uh, essentially, the PhD involves a co-designed intervention.
Okay.
And what I mean is that it's going to be designed in partnership with various different stakeholders, various different clinicians, but importantly, the target population, the voices that are hard to reach. And this involves migrant populations, refugee populations, and we do have a significant sort of demographic shift here in Norway, where we are seeing more and more refugee and migrant populations. And what we find is our healthcare system and our interventions are not equipped to deal with this, and we are a bit behind the
Yeah.
curve.
Yeah.
And we are catching up and we are going in the right direction, but it
Yeah.
is a rapidly changing demographic. So,
hmm
in partnership with these populations, with low socioeconomic populations as well,
hmm
so that's incredibly important. And essentially, it's revolutionizing the chronic kidney disease management pathway. So, switching it from reactive to proactive.
Yes. Yes.
So it involves setting up a national digital kidney school, having a national curriculum for patients to follow, and also a mobile monitoring platform, which reduces the agency from the patients in order to seek help. And there will be persistently and consistently monitored as well throughout their sort of CKD journey,
Amazing.
involving patient-reported outcome measures, and it's integrated in the healthcare system itself, and
Mm,
therefore. The hope is that agentic demand theory becomes a conceptual bridge between health equity, implementation science, and health system design. So enabling us not
amazing.
only to explain why inequalities arise, but to build health systems that are equity embedded at their very core.
That's amazing. And you just reminded me, I
Yeah.
want to give a quick shout out to
Yes.
one of the authors that you highlighted in your work and included in this, which is Professor Cameron Kaplan at the USC Gare Center for Health
Yeah.
System Science and Innovation. And I just want to shout them out because I know they're doing such great work and very in alignment with this topic as well. And just an engine here in LA and around the world, since it's reaching you across the pond, for health equity research. So just want to give a shout out to them and the work they're doing. And I think it just speaks to, like you said, how this work does translate to different countries that are experiencing
Yeah.
similar challenges in their health systems.
Yeah, and from my recollection, Professor Kaplan and colleagues had the insurance sort of
Yes,
cost sharing model, didn't they? And yes, it was one of the interventions that really markedly reduced health inequity in the target population. So no, incredible stuff, and it was a fascinating read as well.
yes, yes. No, I need to follow up with him. He's great. Um,
Brilliant,
moving
fabulous.
forward, I want to talk a little bit about some of the comments we got when sharing your paper related to sort of the structural level versus individual level interventions.
Yeah.
You guys highlighted, cash transfers, smoke-free
Mhm.
laws, housing policy. These are all politically driven. How do
Yes.
people in public health and other types of settings in our communities help advocate for these types of solutions within their own field, whether that's policy or if you're maybe a
Yeah.
grant writer or someone in the nonprofit sector?
Right.
How do we start to apply this to other types of sectors as well? Because I think that we can, but it's
Right.
also, still understanding how where it comes from.
Right. Of course. Yeah. Um, In essence, I think the starting point is to reframe structural interventions not as ideological choices, but as evidence-based investments. The question
Mm,
is not whether they are politically ambitious, it is whether they produce greater and more equitable populations than the
yeah.
alternative. We also need to move beyond judging interventions solely by their short-term outputs, and it is unfortunate, but politics often does run on quite
Yes.
short-term cycles, whereas in public
Yes.
health, we're often quite long-term thinkers,
That's a good
thinking many
point. Yeah.
generations
hmm
beyond. So structural policies often take longer to mature and materialize, but they address the root cause of ill health and therefore have the greatest potential to generate sustained health and social and economic returns. I recall seeing some studies quite recently, actually, and I can use the UK as an example, but we're a much, much smaller economy than the USA. Nevertheless, health inequity in the UK sets the government back at about 50 to 55 billion pounds every single
Yes.
year.
Yeah.
Yeah. That's almost a third of our healthcare budget simply gone on inequity. We've always used the expression it's expensive to be poor.
Yes.
And I think that
Yes.
applies at macroeconomic levels as well. Importantly, this is not an argument against individual level programs. They do have a place within society and they do have a place within public health. Rather, it is about ensuring that they are situated within a broader system that reduces the structural barriers that people face, rather than expecting programs alone to compensate for them.
Yeah.
So, public health, therefore, has a responsibility to articulate the economic as well as the moral case. Health inequalities carry enormous costs, as I've just mentioned, through avoidable diseases, reduced productivity, greater demand on public services, and lost human potential as well. Now,
Yeah.
that gives us both a moralistic case to reducing health inequity. I think it's quite hard to argue against, irrespective of your political persuasion.
Yeah.
But it also gives an economic case as well. And oftentimes that we do find that um, engaging in these economic discussions can be quite productive, especially with people outside the public health
Yes.
realm or in that sort of political realm. So it's an investment in social resilience rather
Mhm.
than recurrent wasted expenditure. And ultimately, the conversation should shift from asking, what is politically easiest to fund today?
Mm.
And what we should be asking instead is which investments are more likely to produce equitable population health over the next
Yeah.
generation? And it's about bridging that gap. And I think that's incredibly important.
It's kind of a fight, if you will, between sort of,
Yeah,
short-term viability and
yeah,
then long-term outcomes, right? Like we know we can
absolutely.
get this thing done, but it may not have the same impact,
Yeah,
right?
yeah,
Than something that
absolutely.
really is structurally changing the root cause of inequities or health
Precisely.
disparities.
Precisely. Yeah, yeah. And I think you'll find that, across different governments across different countries. I've worked in the UK and I'm now working in Norway. Having these conversations, these fundamental conversations about public health and generational health equity, and you're focusing on this life course theory from the first 1,000 days of
Yep.
development, setting up your health in middle age and later life.
Mm.
And it's difficult to convey to politicians and people involved in politics whose um, outputs and thinking tends to span, an electoral cycle of 4 to 5
Yep.
years.
Yep.
It's a difficult one to convey, but I think there is an economic argument there to be had.
Yes. Yes. You're
Yes.
reminding me of a global health and human rights class I took years ago, but
Yeah.
we're just talking about that political shift and that pendulum
Yes.
swing and how much that affects all
Yeah.
of our work and just having to navigate that as well, um,
Absolutely.
throughout the longevity of
Absolutely.
our careers.
Yes. Yeah.
So
Yeah.
speaking
That's
of that,
incredible.
looking at that, I think
Yeah.
it's very interesting that when we were talking before, how much similarity there is in
Yeah.
systems like Norway and the UK, because I think growing up in the
Yeah.
US, those seem to be sort of the gold standard for socialized medicine and
Okay.
everyone having
Yeah.
access
Yeah.
to care.
Yeah.
And we see the ratings are higher in places like
Yes.
Finland and Norway for Gini coefficients and happiness
Yeah.
metrics. And so to hear that you still are dealing with health disparities and challenges accommodating or expanding services for migrant populations, it's we are dealing with the same challenges. So even though this
Absolutely.
does include, different types of safety nets from around the world and developed countries, um, and our US system is somewhat unique, right? We have sort of this patchwork system. We've had different
Yeah.
policies over the years. We're
Yeah.
currently seeing sort of a rollback in welfare in general and welfare retrenchment in terms of who has access to what services and why, in terms of our
Absolutely.
political environment. And I think that has a direct impact on all of the equity gains we've seen.
Yeah.
So from your perspective, in terms of the US, like how do we translate this in this current climate? And what do we do with the parts of this that we can't take with us or that don't necessarily translate?
Yeah. So, I think the first point is that the underlying principles remain remarkably consistent
Yeah.
even when the health system's different. We found this in the paper as well. So, whether healthcare is publicly or privately financed, interventions that reduce unnecessary barriers and require less individual effort or agentic demand
Mhm.
are consistently more likely to reduce health inequity. And the review should therefore be viewed as a framework rather than a blueprint. We should not expect individual policies to be directly transferable across countries, but the
Yeah.
mechanism through which they influence equity are highly generalizable. And again, this was remarkably consistent across all 35 systematic reviews, and we did have good sort of coverage across OECD countries. So we had almost an equitable split between papers in North America and Europe.
Okay.
Um, And in more fragmented systems, such as the
Mhm.
United States, this means identifying opportunities to reduce agentic demand wherever they exist. And that may be through integrated care pathways, community health workers, digital navigation, benefit enrollment, or partnership across health and social care, even where national policy reform is not immediately feasible. And at the same time, we should be honest about the limits of implementation. There are aspects of structural inequality that frontline practitioners cannot solve in
Yeah.
isolation. That is quite a depressing reality that we often find.
Yeah.
And recognizing those constraints, is not always pessimistic. It's essential for redesigning realistic and effective interventions. And I think we touched upon this in terms of some of those clinical interventions where they were culturally and socially and again clinically tailored to those target populations, and they had
Yes.
a profound effect on these clinically and socially vulnerable patients. Ultimately, I think the pyramid offers a way of thinking than a fixed set of policies. It encourages every health system to ask the same question, and which is essentially how can we redesign care so that achieving good health depends less on the resources, resilience, and circumstances of the individual, and more on the responsiveness of the system itself. And I think that that question is absolutely key to any sort of frontline practitioner or policymaker or stakeholder, actually, across different healthcare systems and country settings.
So just really honestly and mindfully shifting the burden as much as you can away from the patient, because we know
Yeah,
that that burden is always going to make it harder for them to adapt or use
absolutely.
that intervention.
Absolutely. Yeah. Yeah. And it was interesting, Haley. I had a meeting just earlier today actually with a nephrologist from John Hopkins.
Mhm.
And one of the things we were discussing was around this doctoral project and implementation science. And we touched upon some of the rapidly changing demographics in Norway in terms of a large sort of refugee and migrant population, which has only sort of materialized over the past decade, 2 decades at most, and also rapid urbanization as well, which comes with its own set of problems.
Oh yeah.
And the one sort of topic that we discussed, and one of the subjects that we broached was about this idea of implementation science. And I think the one aspect that the US has going for it is an incredible amount of experience, a wealth of experience working with disadvantaged populations
Yeah.
and deprived populations, and actually how to engage these populations as well. And some of the suggestions that came out of the meeting today were incredibly helpful, and found all sorts of, obstructive and behavioral change elements that hadn't
Mhm.
occurred to me actually.
Yeah.
So I think, there is that element of experience dealing with populations that, to put it bluntly, are collateral damage from the
Yeah.
healthcare setup that exists in the USA.
Yes.
But I think that experience counts for something, and I think a lot of those clinical interventions, marry quite nicely with that pre-existing experience of working with these
Yes.
target populations.
We unfortunately have a lot of experience working through our
Yes,
health
yeah,
disparities here.
absolutely.
And
It's a
yeah,
misfortune, but yes, absolutely,
I think it
absolutely.
comes with being one of the wealthiest countries in the history of the world is that we have a
Yeah,
big gap between the people who have access to that wealth and what it
absolutely,
allows them, which is
absolutely.
literally 10 more years of life, if not more.
Yeah,
And so
absolutely,
that's what we're talking about here.
absolutely. Yeah,
Your life,
yeah,
how much life you are able to live and how healthy of that life you're able to live, right? How much good
absolutely,
years you get. Um,
absolutely,
and it shouldn't vary based on your zip code, but we know that it does. And so a lot of this
absolutely.
work is geared towards
Yeah,
shifting that,
yeah,
making it more of an equal playing field, literally, which is what I think equity is all about too, right?
absolutely, absolutely. No, absolutely well said. Yeah, yeah,
So just to close out, I think there's a lot of good nuggets that people can take from this. I'm
yeah,
actually going to go back and write some of your quotes down because I thought they were great
absolutely.
one-liners.
Yeah, fabulous.
But
Yeah, yeah,
if someone's going into a budget meeting right now, LA has a lot of budget challenges. Our nonprofits are struggling. Different researchers are looking for ways to move forward their equity research too. What's an argument from this research they should have in their back pocket for something that people
yeah.
can kind of come back to quickly?
Yeah, yeah. I mean, the research and the financing ecosystem is incredibly challenging at the moment.
Yeah.
And the one argument that I would put forward is that equity is not a peripheral outcome. Sometimes it's treated like one or an afterthought, but it's not a peripheral outcome. It is a test of whether an intervention is structurally well designed. If an intervention requires high levels of time, literacy, confidence, navigation, digital access, or repeated self-advocacy, it will often benefit those already best placed to use it. By contrast, the strongest equity gains tend to come from interventions that redesign the conditions around people, including housing, income support, regulation, service access, and the wider environment, things that we consistently found across our research and across the paper. And actually, we'd briefly touched upon the previous umbrella reviews as
Mhm.
well, by Bammer and colleagues back in at the beginning of the 2010s, and also by Thompson in 2018, that found remarkably similar findings to
Yeah.
ours, actually, albeit a different conceptual framework, but the findings were remarkably
Yes.
consistent. So we know what works in these
Yes.
populations. And
This is
in
not
a
a new
budget,
idea, but the way
it's
you're
not.
describing it and
It's
the
not.
way you've laid it out, I think
Yeah,
is refreshing and it gives people a way to think about
absolutely.
it that's new.
Absolutely. There's a way of accessing the findings
Yes.
from outside of academia, but the findings are not radical in themselves. We've
No.
known about this for at least
Yes.
well, decades now, actually.
Yes.
But on that question on the budget meeting, and I know that the research funding ecosystem is a challenge at the moment. But the question should not simply be how many people will get this program reach. But rather, I think we need to shift it to who is least likely to benefit unless we change the design. And the one argument to carry forward is this: if we are serious about reducing health inequity, we should fund interventions that demand less from individuals and require more intelligence, responsibility, and responsiveness from the systems rather than punishing the individual. And I think that is the absolute key. And I think that is the takeaway nugget from all of this, I believe.
Love that. I love that. Well, thank you so much again, Dr. Chatinder, for your
My
time
absolute
today.
pleasure. Thank you so much. My
I
pleasure.
also want to shout out your co-authors, Ellie
Yeah.
Koenig, Helen Pierce, and John Ford, who contributed to
Yeah.
this work. Thank you so much to all of you. This is amazing. And I hope we
A
can
big thank
continue the
you. Absolutely.
conversation.
Fabulous. Fabulous. Thank you so much, Haley. Really appreciate all your help and thank you for providing this platform as well.
Awesome. Thank you so much.
Brilliant. Fabulous.